Families and assessment and interventions. So with each family has its own uniqueness as it incorporates all the individuals and their need to be or have autonomy. So we're going to be looking at relationships amongst family. We're also going to be talking about some of the struggles that exist between family relationships and areas in which family may wish that things could be better or would like to make improvements. The involvement of families when it comes to children, many of them do not have that family support as they need to, and so it results in them having difficulty adjusting, and so they're at more risk for having a mental illness. Today, families are the largest group of caregivers for the mentally ill. Like 2/3 of the patients hospitalized, they end up returning back to those families, and that's why it's important for us to have the involvement of families. That treatment just does not exist just for the individual who's suffering, but again, that whole unit, that whole family system. And so, as psych nurses, we and I mean change that because I've had this revelation that I believe that nurses in general, no matter what unit you're going to be working on, whether it be med surg, whether it be psych nurses, that we have to work with the patients, but we also have to work with their families. So family is defined as two or more people who reside together and they share resources. They're related by birth, marriage, or adoption, and they have a commitment. They develop this commitment to one another over time. And it can include one person and their family pet. Other types of families, as we start breaking that down, include the family of origin, the nuclear family, the blended family, the dyad, and the extended family. So when we're looking at the family of origin, that family of origin is the family that you're born into. With your nuclear family, it's you leave that family of origin, so you're grown up, you become an adult, you start your own family. And so that consists of two or more people who are living together. They can be related by blood, marriage, or adoption. In your blended family, sometimes either due to loss or divorce, two families come together, there's a remarriage, and so now that family becomes blended. With the dyad, that's just two people who make up a family unit. And with your extended families can include individuals from your family, your nuclear family. It could be members from a blended family. It could be anyone who you add into your family as this is a father-like, mother-like family connection that I have. And these new relationships can either be people that we bring in. It could be, again, that connection can be birth, adoption, remarriage. And that family dynamics is going to change, whether it be through loss of someone, again, through death, or loss of someone through divorce. Changes that can happen within a family structure include size, role, mobility, and composition. So what does that mean? As far as the size, it can decrease. Sometimes it can increase. But usually the family structure is not as big as it used to be. My family comes from a family of 13, and now you see more families of 5 to 7. Each person has their roles. There's always been the woman's role, the man role, and that has changed because 46.9% of women right now are in the workforce. And now you have men who are actually involved in parenting. So it's a shared responsibility of not only being in the workforce, but also caring for the household. With mobility, it increases with the change in residences. With composition, it could be unmarried couples, single parent families, and step families, childless families, and then the recognition of your LGBTQ families. What are the tasks within those families? Those tasks include the physical maintenance and safety of all the individuals that are there. How do we use our resources? Who does what assignment? Dividing all that labor up. The socialization of each person in that family. The reproduction, and then the release of family members as people move, or go to college or go to school, get married. What's the order of maintenance, the authority? Who's making those decisions? Where's everyone's role within society, or the expectation of each member's role in society? How does how do you motivate? What are the morals, and how does each person show their affection and love? How do families work together when there's a personal family crisis? And then what are some rituals and traditions that are common or known with amongst that family? These are some of the things that we're thinking about too when we're assessing our family. All of these tasks that you'll see here can directly or indirectly contribute to an individual's mental health or illness, depending on it being adaptive or maladaptive. So if it's positive and all of these tasks are being completed and functioning well, then it creates mental health. And when things aren't functioning or some of these tasks are absent, then it can tend to lead to a mental illness amongst a family member. So when we're thinking about a family unit, we also have to be thinking about the developmental stage of each person within that family. So you have your beginning family, you got your married couple, you have your early childbearing. So that can range up to 30 months. Your preschool child is anywhere from 30 months to 5 years. Your school age can go from 6 to 13, your teenage from 13 to 20, and then you have that launching off point in which your oldest child leaves home. You have that middle year where the empty nest is being experienced by the adults and everyone there is retiring, and then you have your retirement to old age, and that can either be the existence of both, but at some point there may be the death of either or both spouses. So when we're thinking about mental health and family dysfunction, remember that in the beginning, in chapter 1, it kind of goes over mental health and mental illness. Mental health is established because we have really good coping skills, and because of the family dynamic, no one in those coping skills, no one needs to be medicated. They don't have a mental illness. Mental health can also come from individuals who may not have had the best family dynamic, may need a little bit of assistance through medication or cognitive behavioral therapy, but because they're stabilized, they're mentally healthy. Mental illness only comes in when there's an unstabilization or a dysfunction in that person's life. And a lot of the times that leads back to things or tasks or roles that were missing throughout the family. So remembering that mentally healthy families, they're living in harmony within that family unit. They're functioning well in society, and they were either nurtured and are capable of nurturing others within their lives. Within a dysfunctional family, interactions, decisions, behaviors of each individual person is maladaptive. And so when that happens, there's prone one or more individual are going to be prone to mental illness. So what are the 8 rules of dysfunctional families? 1 is about control. One must be in control of feelings, behavior, and relationships. Perfectionism, have to be right about everything. Blames themselves or someone else, uses them as a scapegoat. Denial, of the five freedoms: denying feelings, thoughts, perceptions, wants, and imagining. No talk rule. Don't talk honestly. Myth making. Look on the bright side. There isn't a problem. Incompletion. Stays upset and confused without resolving differences. And there's an unreliability. Don't trust anyone and you'll not be disappointed. These are some of the rules that can add to members of a family being dysfunctional. Healthy family characteristics. Signs of a healthy family includes the ability to cope throughout changes and stress, can apply the skills they learn, have a healthy nuclear family relationship, and can experience absence or deal with conflict well when the family is unhealthy. If you look at your demonstration here, it also includes being able to communicate in a way that builds up and creates an unshaken bond and a really good level of understanding. They accept each other. They have zero tolerance for physical abuse or toxic behavior. In a healthy family, it's about rebuilding relationships that may have been damaged, and it makes it a priority. And in a healthy family, every member gets involved, works, and plays together. So, healthy families are going to consist of, again, communicating, having each member have their roles and expectation. They're going to support and nurture one another. They're adaptable in the face of stress. They deal better with developmental changes and are very hopeful about the world. Problematic family characteristics include people with inadequate relationship skills. They may have mental health problems, diagnosed or undiagnosed, behavior disorders, troubled relationships, psychiatric disorders, unresolved family of origin issues. So maybe there are adult children of alcoholics or survivors of incest or abuse. So when we're doing our family assessment, one of the things we talk about a lot is a genome, and I included this one because I think this helps people uh, kind of have a colorful way of understanding how a genome goes. But when you're looking at your family assessment, a nurse has to be able to decide whether the problems lie only in the nuclear family or whether or not it extends outside of that. They have to decide if the problem is from an unresolved conflict within the family of origin, or if the problem is a combination of both. And your textbook has a really good example of this. But when you're looking at that genome, your genome is going to include age, when everyone got married, death, what was the geographic location. With that, there's going to be some family history, composition, relationships, and illness to be able to, that's going to be included in the information to determine the possibility, plausibility of mental disorders outside of the individual that's being treated or other significant health problems. So mental illness can have its effect on the family's ability to function. And so when you have a family member or an individual of a family that has a persistent mental disorder, several things are necessary. They're going to need support. They're going to need information on that mental disorder, services that are able to monitor the progress of that individual, and also we need to advocate for services. When we think about chapter 1, it talks about the stigmas. It's not chapter 1, it's called Fighting Stigmas and Recovery, I think. That it talks about the stigmas related to why individuals don't seek help, or even when they receive help or apprehensive about using it because of the stress that it causes. But it's not only stress on that individual, it's stress on the caregiver because it can create isolation, financial stress, conflicts, and low self-esteem. So what are we going to be thinking about when it comes to family coping difficulties? There can be patient conflict between being dependent and independent, side effects from medication, not being compliant with their medication, Sometimes, depending on what their mental illness is, there may be some bizarre behaviors and communication that may be present, the inability to be able to engage in their ADLs. They could be exploitive or very provocative with their behavior sexually as well. Lack of cooperation, avoidance behavior, whether it be their mental illness or substance use abuse. They can have lack of insight, be in denial, or have poor judgment. Social isolation, a lot of that has something to do with not only the disease process, but also the stigmas that go along with it. Suicidal ideations and attempts, behavior that's maladaptive, like being hostile, abusive, or threatening, moodiness, and being intrusive. There's some general symptoms theory that says that there's interrelatedness of parts, or that change in one part affects the whole entire family. Boundaries involve, if they're open boundaries, involve accepting members as individuals so that they're comfortable and want to be home. But sometimes the roles and expectations are not outlined the way they need to be. There's tension and stress modulation. So, are they reacting appropriately? Equilibrium says that there's going to be some adaptive coping. And with feedback mechanism, families modify their structures as each individual grow and change. With blurred boundaries, you start to have things like triangulation. So there's a three-person or triad emotion reaction that makes it a third person is actually brought into the middle of this. In most families, unfortunately, sometimes that usually is a child. There's the disengagement where the family boundaries are rigid and permeable. So there's really little loyalty, and for families members itself, but also for the medical community, it's really hard to handle relationships or families when this disengagement is present. With enmeshment, there's an over involvement or lack of separateness between the family members, and with skew, there is a individual who may be severely dysfunctional but appear complementary, and we'll talk about that just a little bit in my notes as far as how this affects the family. Just make sure that you guys read over that. There's some other theories which we're going to talk about coming up in the next slide that include Bowen's theory. Bowen's theory says that individuals have a low differentiation of self. So there's a focus on intimate relationships. Energy is on having affection and approval. Decisions are made based on feelings or input from family. There's a high degree of emotional attachment to parents, or there might be some emotional cutoff, or that the person takes a spouse with a degree of differentiation. With the nuclear family, Bowen's theory says that there's a pattern of interaction and emotional functioning among parents and children, and that there's also a moment in which there's a replacement of that family of origin. In the nuclear family is interlocking. There's some fundamental building blocks, and that there are expectations of internal and external changes when emotions become tense. So tension increases when there's just two people. So by having a third person in that triangle, that third person is kind of brought in to kind of solve the crisis or to offer an understanding. Again, as I mentioned before, though, sometimes there can be a child, and if the child's not old enough, it can cause a trickle-down effect of dysfunctional, maladaptive behavior in a child. However, that third person can be a child, it can be a friend, or it can be a parent. but just some cautions when individuals are using a child as that third person. In communication, there's healthy family interaction. It should be clear communication. When there appears to be some dysfunction within family, that's more because that communication is impaired. So it's important to be clear and direct in what's being said, what's needed, what each individual needs, and that each individual needs to have a sense of feeling respected and loved. With impaired communication, you'll see a lot of times scapegoating, and so they'll blame a member of the family for actions of someone else. With marital schism, one spouse belittles the other. With mental skew, there's a maladaptive way of behaving that becomes acceptable. With a double blind message, there's positive vibes or messages being given, but then turned around to be giving negative messages. And so it's almost like commending somebody in one sentence, but then saying, but what you did wrong was. And sometimes I can just give mixed messages. And then there's pseudo mutuality, which implies a sense of relatedness when there's actual superficial sense of unity. In functional families, individual members as a group adapt effectively. Adapt to change effectively. They promote transactions developmentally amongst one another. Boundaries remain very well defined and at the same time flexible. And there's adequate feedback in place to maintain this open system of communication. In this slide, please feel free to blow it up because you begin to see what it is like to have the type of work that is put in when you're doing a family assessment. For instance, when you're doing that assessment of your family, you're going to be looking at who the members are, what their health status is like, what's their mental health status, how does it impact the family, what is their family life cycle like. Okay, well, let me get this in view so that you guys can see it. To look at the communication patterns that are happening. How are they doing when it comes to stress and coping and problem solving? What is their family system like? What is it composed of? What other health and illness patterns do they have in their relationship patterns? So just zoom in on that a little bit to kind of get a clearer idea of what that family health assessment is like. So we're at this point where now we're assessing family. So we got to look at physical, and this is all about Maslow's hierarchy, that before we can deal with an imbalance to mental health, creating a mental illness, we need to be looking at physiological factors that may be impacting. So with their physical health status, we're ruling out any physical illness, any disabilities, or problems that can affect the family's ability to function. Then we're looking at their mental health status, looking at what histories of mental illness exist across all the generations and how this impacts the family. In addition, you'll also see this little illustration that I have, that we're looking at that physical, that psychological, that social, and that spiritual aspects that can affect that family functioning. Family development, that family lifestyle, refer to your textbook in that. You're looking at cultural variations, how the family works and deals with family conflicts, and thinking about how families pull their resources together, especially if poverty is a part of that family's life. If that's a point of reference for them as far as things that may interfere or with their ability to function adaptively. How do they communicate? What's their stress and coping abilities? What problem solving skills do they use as a family? From the social domain, we're looking at that, how the social and financial status of each family, what their occupations are there cultural expectations and beliefs that they consider? And then what is their support system, formally and informally, as far as that network is concerned? Formally, are they using hospitals, agencies, self-help groups? Informally, do they prefer to use their extended family or friends and neighbors as their support system? And then we start looking at, because we're including family into our care of our patients, now we're thinking about diagnosis that might be present that we want to look at as nurses in developing a plan of care. So, is there ineffective family therapeutic regimen management? Or it could be disabled family coping, interrupted family processes, compromised family coping, caregiver role strain, ineffective denial, or complicated grieving. Interventions that we're going to do to help the patient in their family life, but also when we're treating family, is encouraging them to use counseling, to promote self-care activities, to support family functioning and resilience. And so with that resilience, we talk about that a little bit when you guys get into child and adolescent. But with resilience, it's that person's ability to adapt to change, whether it's negative or positive, and to understand that change is not a death-dealing blow, and that it can be overcome. The expectation that not everything in our life is going to be good, and sometimes it's going to be bad, and that we can get ourselves through that. Then provide them education and health teaching. And then important to collecting information for plan of care and doing the interventions is going back to that slide that we talked about, when the RN uses a genogram. And that information can be found in your textbook. And that ends this material.